So a lot of times we have post-refractive patients, and these patients are ones who've always expected to have great uncorrected vision. Now, many times when these patients come in, they may have some residual astigmatism. So we want to go ahead and correct their astigmatism with a toric lens. But then the question comes down to, how do you determine what lens to use?
I think success with a toric lens in these patients comes down to three things. You want a lens that's rotationally stable, so your outcome is durable over time. You want a lens that's forgiving, so if you don't achieve your refractive target, there is some wiggle room. And then of course, number three, you want to achieve your refractive target.
What I really like about the Rayner EMV lens and that toric fashion is that it has this positive controlled spherical aberration. And where it is utilized extremely well is in patients who've had previous hyperopic LASIK. They have a certain amount of negative spherical aberration. And because of the controlled positive spherical aberration, it helps to go ahead and neutralize that and will help to give us a better overall result.
Yes, and I think the positive spherical aberration is also useful just in virgin eyes because normal corneas have that positive spherical aberration and it mirrors that. And I think it also has a little bit of an extended range, right? Which gives you a broader landing zone and allows you to hit your target easier.
Exactly. We know that in post-refractive eyes, hitting the target is a little bit more challenging. And so if you've got a lens that basically has a more flatter depth of focus curve, then you have the ability that even if you're off on your ocular biometry, you can hit the target and there's a greater likelihood that you'll end up with a patient with 20/20 vision. The Rayner lens is actually, from a surgical standpoint, is, in my mind, one of the easiest lenses to work with. It comes in a preloaded platform, and it's basically just a two-step process. You go ahead and inject the cartridge with OVD, and then you just close the cartridge, and it's ready to be injected.
Because it was preloaded, there was really no thinking before having to inject the lens. I like that the haptics unfold almost immediately, so there's no sticking of the haptics. When framing the cost and value conversation for premium IOLs, I never focus on lens technology or branding. I think patients care a lot more about what they can do functionally with their vision after surgery. So I focus a lot more on how this would be an investment in their overall functional vision, their quality of life, and I think that is a lot more meaningful to patients.
What I like to do is I go ahead and have a conversation with the patient. They go and tell me what type of vision they'd like. And a lot of patients want to have great distance vision and potentially maybe some range of vision. And that's where a monofocal lens plus technology works really well. And with the Rayner EMV, where we've got this controlled spherical aberration, we have the ability of going ahead and giving that little bit of range. So I find that that works very well in that situation.
When it comes to hydrophilic acrylic as a material choice, I think that it's important to have a more nuanced, evidence-based approach. Calcification is real, it has been reported, but it's context-dependent and extremely rare in routine cases. We don't put them in eyes that may need future intraocular surgery, so patient selection and being really thoughtful about who you're putting the lenses in is really critical. But overall, in healthy eyes with normal corneas and normal retinas, it's a really, really good lens that performs extremely well.
I would say that at the very beginning, I basically was not certain how well they would perform, but we've actually gone ahead and inserted thousands of hydrophilic lenses. And all of these lenses, they look extremely pristine inside the eye. The optical material is completely glistening free, and it's very biocompatible within the eye. If we find a patient that may have some type of preoperative pathology, like perhaps they have Fuchs, or we think that they may require some type of surgery in the future, then we may avoid a hydrophilic lens. But otherwise, like you said, in most routine cases, I think this lens performs extremely well.
With multiple toric options available, I think the EMV Toric really stands out in a couple of ways. I think it is a great option for someone who's looking for maybe mini monovision, but you don't want to commit to that anisometropia because it gives you a little bit of range. It's great for post-hyperopic LASIK eyes, and it's also great for someone who wants range but isn't a good candidate for multifocals or diffractive optics.
Yeah, and I think the biggest thing from a toric perspective is that ultimately when you place any type of toric lens from any brand, what you're looking for a lens that will be very stable inside the eye. What's nice about the Rayner platform is that when you look at their overall haptics, they've got a very broad design that has great contact with the capsular bag, so that once you go ahead and implant it within the bag, then the likelihood of rotation is almost slim to none. It does a fantastic job of staying exactly where you leave it. If a colleague asked me whether or not I should try the Rayner EMV Toric, I would tell them absolutely yes. I mean, the best part about the lens is it's something that people don't realize the range of vision that you can have and have great quality of vision.
It's interesting, I was just asked this by 2 different people today, and I said absolutely worth incorporating into your practice. It's just another tool in your toolbox to individualize refractive outcomes, and that's what modern cataract refractive surgery is all about. And I think from a patient experience standpoint, it's a really great lens too. I've never really heard a patient complain about dysphotopsias or other sort of higher order aberrations due to the optics of the lens.